These are in listen-only mode.
Thank you, everyone, for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is Population Health Can Improve Practice Profitability. Really? We're joined today by Dr. Mark Crockett of Rise Health. Dr. Crockett has been a pioneer in the accountable care movement with extensive knowledge in the fields of emergency medicine, medical informatics, and systems architecture. In addition to his considerable experience in health technology, Dr. Crockett practices emergency medicine at Good Samaritan Hospital in Downers Grove, Illinois. We are delighted to share his expertise with you today, and we thank Rise Health for making this session possible. Let's glance at the questions for today's session while I go over some quick housekeeping notes with you. Remember that you can ask questions of our presenter at any time during today's session by entering them into the chat area. In the second half of our presentation, we'll address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, remember that all registered attendees of today's session will receive an email with links to both the slides and the recorded version of the event. So we often get questions about whether or not you'll be able to review these slides. Rest assured that we'll send those out to you after the event. Well, before we begin, thank you so much for joining us today, Dr. Crockett. This is an exciting topic, and we're really pleased to be able to share your expertise.
Oh, absolutely. It's great to be able to join you, and appreciate everybody's time.
Well, you know, HEMS just wrapped up last week, and population health was all over the place at HEMS. Why is it such a hot topic right now?
I was down there for HEMS. Orlando was a really nice place to be compared to Chicago, where it's been freezing cold.
Yes, indeed.
I think you'll agree there. I think population health has become top of mind because of the place that we've come to in terms of medical cost. There's been a lot of discussion for a long time about medical costs being unsustainable. However, costs continue to rise. Now we're in a place where most of the major payers, particularly CMS, have gotten to a point where they have started to change payment methodologies to try to limit that raise in cost. And so there's a large number of physicians and provider organizations who find that they have some fraction of their patients that are at risk for cost and quality, that they're being paid more for outcomes. And under any kind of situation like that, contractually, they really have to get to a point where they understand and do well population health.
So is clinical integration the same thing as population health? And if it's not, what's the difference between the two?
Absolutely. So this is, being that I practice at Advocate Healthcare, that was really a pioneer in clinical integration. This is something sort of near and dear to my heart. Clinical integration very simply means putting a certain amount of financial incentive behind quality and cost reduction. And basically what it does is it allows you to have a number of people who are all aligned from the provider point of view on taking care of patients differently. Integration can span hospitals, a number of providers on the inpatient and the outpatient. But basically what it means is that you're being incented to work together as a team, and population health is actually the goal of a lot of these clinical integration programs. So, our Advocate IPA has, over 1,000 doctors in it. And basically, the clinical integration bonuses are there to make sure that you are doing the best evidence-based care for your patients. But as we look at which patients under contracts where we're at risk do we need to address in particular, and what goals do we need to achieve there, those are the kinds of population health efforts that we're under. So the secret to both of those is the relationship between the physician and the patient. Under any of these contracts, like an accountable care organization, Medicare Advantage, any of these kinds of things, not only does the physician need to be incented to be able to see that they are being clinically successful, and then therefore they're being financially successful, but also you need the patients to do the right thing. You need the patient to lose weight, take their medications, stop smoking. And so for population health, which is mostly targeted at some of those discrete kinds of behavior changes at the patient level, particularly for a particular group of highly expensive and sicker patients. The means to get that done has traditionally been clinically integrated networks of providers that are working together to make sure that everybody is working towards the health of those patients.
So you can correct me if I'm wrong, but my understanding from what you've said then is that you can't really do population health without clinical integration, but at least in theory you could have clinical integration and not pursue population health.
Absolutely. You could have clinical integration and target that at fee-for-service. I'm not sure why you would, but you could. Clinical integration really depends on the incentives, and then how you organize your governance and which groups of providers do you put together in order to achieve some end. Population health is more sort of the goal of controlling costs for a population and getting to better care around that population of people. And it seems pretty basic, but it's an important distinction because clinical integration has been kind of the way in which provider organizations look to essentially do population health. Unfortunately, those kinds of efforts are extraordinarily expensive. A lot of people have to sort of take it on faith that there's going to be a return on investment. So people are doing very large consulting projects with large groups of physicians, putting incentives in place, and then it can be literally years before you wind up understanding whether or not you've been successful around it. And the feedback is so long, and you're looking for physician change and physician buy-in. Clinical integration is extremely hard. The goal is a good one, but those kinds of efforts extremely difficult.
Well, let's dive a little deeper into population health. What are the components of a successful population health strategy?
So any kind of population health strategy requires you to find the patients that you need to be interested in because they're either expensive or about to become expensive, and then find the right provider for them to be taken care of. To address the patients that you and focus on the ones that are going to be generating cost or that are at risk because they're missing some element of their care. The classic one would be a patient who is a diabetic who's currently, not well controlled in their blood sugars. Eventually what that winds up being is a patient that generates lots of expensive care, and it's not good for the patient to let that blood sugar go high for long, and it's not good for, the provider organization under any kind of accountable care contract. So, in order to understand that, you need two kinds of data. You need both very broad data that shows you a lot about all of the patients that you are taking care of. You need to be able to see not just care that you are seeing the patient for in your own EMR, but potentially even care that's being done by other people for that patient. And that's typically what you need payer data to do. The insurance company is essentially paying for almost everything, and therefore they're going to have a view of that patient that is much broader than the typical provider organization has. You can also look at things like SureScripts data and other types of pharmacy data to get an idea for care that's being done. Almost any really important clinical event is going to generate a prescription. And so understanding that data can give you that broad sort of surveillance look to say, who in my practice is being seen, what's the total kind of cost on all of my patients, and again, that's usually payer data. At the same time, broad payer data comes in late. You might not get fully adjudicated claims data for 90 days after an event, and so having a patient who's discharged from the hospital 90 days ago and then trying to address their care, the horse has left the barn. So understanding what I call deeper data, which is essentially the EMR, understanding that, that tells you a lot about the current events of the patient. It tells you more about the depth of the kind of care that's being done. And so at this point, in order to get to really good population health, you need both types of data. And then understanding, once you have that data, analytics to figure out who's sick and what, basically who is not sick, who is likely to become sick. And so at that point, you have a list of patients. Typically, that's described as a registry. In a lot of the older approaches, you've been in you take a registry, you hand it to the doctor, and you say, hey, these are the patients that you need to manage differently. Pay attention to those people. At this point, what I would say is that, really a population health strategy without some kind of outreach is really not there. It's not effective. You need to be in a position where you have the engagement with the patient and the outreach so that you can proactively reach out, grab the patients, get them in the door to your providers so that you can address the core causes of both quality problems and cost problems.
So what are some important elements then of an effective population health strategy?
Well, to a certain extent, you're looking for behavior change, and this is one of these interesting things. The patient's behavior change is hard. I mean, it really is, and it requires a level of engagement with the healthcare system that we haven't necessarily in the past needed. As an emergency room physician, frankly, under fee-for-service, my incentive is to see you get a little bit better. But then, if you come back, I get paid for that. So it hasn't necessarily been, behavior change hasn't been necessary. As we get to a point where we're being paid for outcomes, this is a much better set of incentives for the patient, better incentives for the doctor. It really is a much more aligned system. But you really have to engage those patients. And so, what we find ourselves in the position is looking at what causes patients to do things differently? What causes them to make their appointment, get in and get seen? What causes them to, take their medications? And, to a certain extent, that is all in the relationship. And I think that that's one of the things I'm very passionate about is that relationship belongs in the hands of the provider. You just need a backyard conversation with a bunch of your friends to say, hey, who picks up the phone when their insurance company is calling? Versus who picks up the phone when their pediatrician is calling. Right? The physician has a current relationship with the patient, and the practice has a current relationship with the patient. And so, expanding that relationship, making sure that it's the kind of customer service that you would want to have from any organization, has become ever so much more important. I think that what we've seen is that patients have higher expectations for customer service in the age of CRM and in the age of big data analytics in the retail industry. They don't expect to call and get somebody who doesn't know who they are or what they're talking about. And so this level of customer service on the provider side really reinforces that relationship. You also need to be able to take care of patients differently. You need to have access to care. If as an ER physician, I can tell you that if I have a patient that calls one of the family practices and says, I have the worst sore throat of my life, and then they're given an appointment 2 weeks away, that's going to generate an emergency department visit. If you don't focus on access, you're going to be in a position where you're going to have a very difficult time doing any kind of really responsive population health. And so, practice transformation where you have, great access, you have great patient relationships, that's just absolutely critical to being able to do, to gain the benefits of clinical integration.
There's a lot of great points you made in there, but on that last point, we're at the point now where I've read that private insurance companies are even just sending people to ERs for relatively manageable complaints like you're describing, certainly not emergencies, when acute care of some kind, urgent care rather, would be perfectly fine for their problem. And that just shows a total breakdown in the system. I mean, it's completely wasted resources when there's a simple solution that everyone understands. It's just organizations are slow to transform.
Well, absolutely, and we're really going back to what I consider a great set of aligned incentives. I really, frankly, love this model. My grandmother was a primary care physician. She did her last house call at 86 years old.
Wow.
She did population health, but it was a very manual process of getting out and seeing the patients on a very intimate level. And those patients reached out to her for absolutely every aspect of their care, and she was very responsive to that. Building that type of intimate relationship at scale so that a provider organization can make sure that that patient feels like they are being taken care of by a team of people that legitimately cares about them is that kind of medicine is being practiced by some of the better organizations in this country. And that type of intimacy, it now has a strong return on investment in these type of contracts. So from where I sit, even as an emergency department physician, who you'd think would tend to be in a position where we'd actually don't benefit from these types of plans, seeing people get the right care in the right environment at the right time, it enhances the patient experience. It lowers risk. I mean, it's the right thing to do.
Well, we just touched on this, but what does practice transformation require? How should people approach this question?
Well, practice transformation has been for a long time, on people's radar as a way to increase efficiency of the practices and increase the finances of the organization. And so, we have been involved in those types of efforts, to, make sure that you're focusing on access and making sure that the physicians aren't doing a lot of extra work. The big surprise for Rise Healthcare in particular, as we were out doing population health efforts, and doing team-based practice transformation in order to do this type, to do this team-based care, was that we started seeing fundamentally significant improvements in practice financials on this basis. So, doing team-based care where the doctor practices to the top of their license, where nurses in the practices are able to answer the appropriate question, and even an MA level person, a medical assistant level person who is able to come in and answer the right questions for the patient at the right time. Under those kinds of circumstances, the primary care physician's office is seen as, in particular primary care physician's office, is seen as a great source of information, a source of coaching, a place where everybody knows my name, as it were. And so, under those kinds of circumstances, you have, really beneficial effects on the practices, financials, as well as on the clinical health of the people coming to see you. For example, give an example of this. You have a patient who's calling into your practice, who happens to be a diabetic, happens to be on your registry, happens to be, a patient who you are concerned about because they recently were discharged from the hospital, but you haven't had contact with them. They're calling you, and because the patient is calling you with a, agenda that's medical, they're calling you with time on their hands. That represents an opportunity for clinical care. It represents a conversation where you can say, how are your blood sugars doing? And if the answer is, I just took my blood sugar and it's 250, understanding that patient should be in your office in less than 48 hours, that kind of opportunity to really interact with the patient shouldn't be missed. And so when we talk about practice transformation, we talk about efficiency. We talk about making sure that the MA level people can do things like medication reconciliation or other types of important, data gathering efforts. But it's also about making sure that the right, that you can use data in real time on the fly to say, this patient is somebody who should be taken care of at a higher level, and should have a particular conversation with the patient. And that's the kind of situation where you incorporate the entire care team and you make population health really a verb, an action, as something you do every day. And particularly if you can target it to the point where you can take your scarce care coordination resources and focus them in real time on patients that you are clinically and financially incented to do so, that becomes a really important and critical aspect of the clinically integrated network experience.
So what's the biggest challenge to population health?
I think, that as we have seen clinical integrated networks get out there, and you've looked at, for example, some of the accountable care organizations that are out there, there's no question that accountable care organizations do work. We've seen, the accountable care organization. I'm just using that as sort of generic, example of a contract in which you're paid to do population health, essentially. We've seen it save hundreds of millions of dollars for the federal government. But then there were practices where it didn't save any money at all. And so, the question is, why does it work sometimes and not work others? And I think the biggest challenge is, when you have a small percentage of the patients in a practice, and you are that you want to do that type of work for, and then you just add it onto the physician workload as, hey doc, here's your registry, make sure you take care of these patients differently. So you wind up with real challenges to the providers getting involved in it, or thinking of it as really an important thing to do. When you do that kind of thing, and then the EMRs, frankly, and I was an EMR vendor for years, frankly, it's just been so many things added to the provider, particularly the physician, that I think there's just a certain amount of, this is just one more thing. It's just one more way of making sure I'm not going to get paid as much. And so, if you just add it to the doctor, that's the biggest challenge that population health has, is trying to push it through in that particular way.
So on the EMR front, I'm very sorry to interrupt, doctor, but on the EMR front, the issue, you're speaking of things like, the kind of unnecessarily complicated workflow that so many folks have experienced, and kind of the frustrations of switching to digital technology.
Absolutely, and I think EMRs are absolutely an important thing. I am in no way somebody who does not believe that EMRs are important, but is it really necessary for the physician to enter every single field? What work could be done by the care team is an important part of our discussions with people. We've had physicians who were working 400 hours in the EMR after office hours were closed, meaning they were seeing the patients and doing all the right thing for the patients and doing the charts later. Under those kinds of circumstances, getting those down to 4 hours a year, that requires some real thought around who needs to actually use the EMR, what information can be put in. It has to be put in by the doctor, and what information could be put in by somebody else. Clearly, there's some important things like writing prescriptions that the physician should be the only one doing, or the nurse practitioner or whoever is licensed to do it. But working to the top of their license is really critical. There was a recent, I believe it was JAMA, where they showed a picture that a child had drawn of their doctor. And it was a picture of the doctor's back as the doctor was typing into a computer. That kind of thing, we shouldn't be in that position. Population health efforts actually are a nice way to organize care around a team-based care, allow people to work to the top of their license, and you wind up with physicians that have are seeing their biggest financial incentive for performing great clinical medicine. This is one of those things where we have physicians who are making a significant amount more financially from doing great clinical care and organizing their teams the right way. And I think that gets around this idea that population health is just one more thing to throw on top of the doctors. And right now, the doctors are busy, right? They're in a high-risk environment. They're in a position where they're being asked to adopt new tools. Some of the tools are a little bit awkward for the practices. Thinking through how you do that, I think, is a really important part of how you do clinical integration, once again.
All right, well, this is a great question because a lot of people have maybe a toe in value-based care, but everybody's moving toward that transition. How can you manage both at the same time in the same patient population?
And this is just really tough. So physicians do not want to bucket their patients by provider and take care of them differently. It goes against everything I learned in medical school. It goes against every family model for physicians that exists in my family. It's just not something I want to do. And so, and that really limits the impact of some of clinically integrated networks. I mean, as you start to say, okay, what efforts can I run? What incentives can I have that I can run across all of my patients, and then therefore, and incent my patients? You wind up with a sort of a generic level And for patients that you would be, for efforts that would be successful in cost cutting or lowering the cost of some of these efforts for patients, for your fee-for-service patients, you wind up potentially limiting your revenues. And so it's a really awkward kind of a position. That said, the practices can behave differently. You have only so many care coordination resources. Being able to focus those on the patients that you are financially incented to do so, and then prove the success of that model allows you to then expand your contracts into ever so much more of that type of model. I mean, if you only have to look at organizations like Kaiser to say that if 100% of your patients you are at risk for and you are aligned in your incentives, you can do great care and be financially successful. And so, if you can, have basically enough data fast enough that's both deep and broad and put it in front of your practice so that you literally can have an inbound phone call and divert it to a practice person, an RN level care coordinator, if that's a patient that requires it, and understanding that as your practice, then you can be in a position where you can document your effectiveness around a certain subsegment of those patients, and then you can simply turn to the payers and say, you know what, this is something we do well. Let's try to take every one of these things, and then that's a nice roadmap to being clinically successful, being financially successful, and then, as it makes sense in your region, becoming a preferred provider for networks under those kinds of scenarios. And we've proven that you can do that at scale. You do need potentially multiple providers data. You need potentially multiple payers data. You need to be able to warehouse that information, and you need to have an integration right into the workflow. And you need it to be able to span potentially multiple electronic medical records. So it's not easy to do necessarily. But the nice thing is the tools are better than they've ever been before, and the smarts about it, the lessons learned from places that are like Mayo, Advocate, Geisinger, Kaiser, all these guys who are really concentrating on this. They really are. This is one of those things where you can really see some successful ways to get successful with the care team. But if you dump it on the doctor and you say, you know what, we're just going to ask you to try to pay attention. The patient doesn't come in with a sticky note on their forehead that says, hey, I'm on your registry and I'm part of an ACO contract that you've got. And so it becomes very difficult for the physicians to take the time with everybody and have those efforts be successful. Does that make sense?
It does. So what's next in population health? There's so much interest in it now. Where are we headed in the near future?
I think the answer is going to be very interesting here. So, down at HIMSS, there were probably, I don't know, somebody mentioned 100 companies that had some kind of aspect of population health. And I think that, it's interesting. If you look at it from the provider point of view, I could buy population health tools from my electronic medical record vendor. But then potentially have trouble with interoperability with other medical record vendors that are out there. And again, getting that broad data, in particular the payer data, can present you with really significant challenges. On the other hand, a lot of payers are now vertically integrating. And so you may have a tool that's being given to you by your insurance company, by your dominant insurance company, or even a niche insurance company. But once again, from a provider point of view, if I have to sign into System A in order to understand get to my population health tool for a couple of patients, and then I have to sign into System B, it really starts to get awkward. So I think where we're headed in population health is, first of all, team-based care just makes absolute sense. Letting the physicians, work to the top of their license. We don't have enough primary care physicians to do it any other way. And so, organizing those efforts, organizing to make sure that we have the top of license providers doing the right thing, that really, outside of healthcare would belong, all those efforts would be centralized in what we call a customer relationship management or CRM solution. And right now, CRM is just vanishingly small in healthcare. I expect to see more interoperability demanded of EMR vendors and payers. I think there is more data available than there ever was, but I think that will get to, there will be more of it available. And I expect to see vendors come forward that are able to organize that data across multiple different systems, aggregate them, and then help with the customer, the patient experience as a customer service effort to make sure that the right conversation is happening with your clinically integrated network all the time. And I think that that really benefits you. If you look at, a lot of provider organizations are currently challenged with, I have another big provider organization in my neighborhood who wants to do this type of care too. How do I distinguish myself and make sure that my patients come to me? This concept of a clinically oriented, customer relationship management system, I think that this is going to come from other industries right on into healthcare, and I think it's going to be a good thing for everybody.
I think this is a fascinating subject, and I absolutely agree with what you're saying. So for people who may not know the acronym as well, the best known of these outside of healthcare is probably Salesforce. But, in other industries, this is now very well-developed technology, and it's kind of a no-brainer. But it's not really present in healthcare, or certainly not in most organizations, which is why you get that, effect of calling the doctor's office, and every time you call, it may seem as if they know you've never even talked to anyone. I mean, once you talk to the doctor, they may know. But when you're just interacting with the organization, it can be frustrating because you feel like you have to repeat the same information over and over again. And a CRM is such an obvious, easy way to address that problem.
Absolutely. And it's not, it sounds easy, but in healthcare, nothing's easy. All you have to understand is that you need a HIPAA, basically compliance with all the vendors that you're touching, that, and you start trying to get somebody like Salesforce to sign a BPA or to understand that, understand the concept of, the privacy requirements. There are organizations out there, I know Innova Healthcare is one of them, who have signed contracts with Salesforce.com to start doing relationship management. And I applaud those efforts. I think that's absolutely fantastic. But I still think you're missing the clinical opportunity. Every single time a patient calls you from anywhere, you should be, understand that that patient's already engaged, that patient's already, ready to talk to you about something in healthcare. The thing to do at that moment is to seize that conversation and say, hey, you know what, we really care about you. But instead of 3 months worth of your Avandia that you're requesting, I see here that you haven't had your colonoscopy. You're seeing 2 specialists that I didn't even know about. There's 2 medications that I prescribed to you that you're not taking. At this point, we really think that we ought to give you 2 weeks worth of your Avandia and then get you in to get you seen. And then at that point, you have really done the right thing for the patient. You've done the right thing for you. And if you're able to focus those efforts around patients that you are particularly clinically incented to manage differently, then as you see success in that area and you can document success in that area, what we've shown with our partners, our practices that we've done some of this organization with, is that they can then turn to the payers in the regions and say, hey, look, I'm doing this. I'm doing it well. I am the lowest cost provider in your area. I have the highest quality provider in the area, and my physicians are extraordinarily well compensated. What we want to do is sign other contracts like this, and it frankly brings into alignment the patient, who gets better care at a lower cost and has a great relationship with their provider, the payer, who sees overall lower costs, although for given practices that their actual payout may increase, and then the physician, who is confident that their entire practice is organized and paying attention. So when a phone call comes in from somebody who is either sick or has the potential to be critically sick, that patient is in the process of getting in front of him or her, in the quickest available time frame, and that they're really getting to the excellent care the patient deserves.
Absolutely. I should not have said easy because you're quite right, but it's such low-hanging fruit when you, as you just described, the clinical payoff, the customer service payoff, the financial payoff. It just seems like something that really needs to happen.
Yeah, and I think it's only, it's only with the recent changes in the incentives, the recent changes in the contracts, that this has become such an important problem to solve, that people have really started to point technology at it. And so I think what we've seen is that the tools are better than they've ever been, that this is an achievable project to get, and as opposed to some of the efforts around clinical integration, which are 3-year multi-million-dollar projects involving changes in physician behavior and governance and everything else, saying, hey, let's talk to our payers and our EMR vendors, get all the data in one place, and then set a bunch of our our current call center type people on this, and start, getting our clinical nurses and our care coordinators really exceptionally, targeted around these efforts and really right into the work stream. That's a 6-month project that winds up with, you're right, really low-hanging fruit, but really important work.
So what options are available to a medical practice today?
Right now, people who are adopting, if you think about it, right now a lot of practices are starting in sort of fragmented care on a fee-for-service model. And so they can either kind of bump along as they see contracts come that are more of an at-risk. So you got 4% Medicare pay for performance, and then in the region is an accountable care organization, and so maybe I do or don't sign up for that. But they can either bump along and kind of try to manually do the work and try to get the doctor to remember to take care of the patients, that are in a particular plan, or they can really get to integrated care. And that, a lot of people are getting the integrated care by being absorbed by or having their practices bought by a regional provider, or joining a progressive IPA that's got some of these kinds of things, and then starting into this clinical integration network. Those kinds of efforts are ongoing all over the country. And I think that, those kinds of, the other possibility is, trying to reorganize your practices and use, technology from the population health space to really get to a point where you understand your patients, get to the analytics that you need to understand who you need to take care of differently, and start transforming your practice. My message is, the option has, I think the option has always looked to providers like, I either kind of bump along at my current level of competence until I have so many contracts sitting there that I'm at risk for that I absolutely have to get something done, or I invest a bunch of money in analytics and population health tools, and frankly, with not really much visibility into whether there's an ROI on that. What the message that I bring you today is that, doing the population health analytics tools and then investing in team-based care and practice transformation turns out to have a truly tremendous return on investment for the practices. It also has a truly tremendous ROI for the payer, and so and that's even under current fee-for-service rules. So I think at this point, I think there's a third option, which is invest and get the value at the same time. And so, and then be prepared for, more accountable type of contracts if they become a really significant part of the reality in your given area, then you're really in a great place.
So these are complicated subjects, and we're going to talk more about what we've covered in the questions, but what should the audience's #1 takeaway from this be?
Well, that healthcare reform, may be one piece of this, but that, the cost pressure on providers, the cost pressure on providers is not about to let up. It is being passed from the employer to the insurance company and down. It's being passed from CMS down, and so these efforts are not going away. And so, we may see a variety of different forms, and it's still not clear to me what are going to be the most successful forms, although the success of the accountable care organizations and lowering costs, I think, is really going to build a fire under those from a Medicare perspective. But I think that, that's just going to continue. And so, being able to look to solutions that have worked outside of healthcare, like CRM, and focus on access, focus on the right care to the right patients at the right time, that can provide a significant and reorganizing to team-based care, that even under fee-for-service that makes sense, and you can get a huge return on investment out of it. As you start to get into contracts where the patient, the provider, and the payer are aligned better, that is just that's a great place to work when you're in a place when you're under that framework with patients. As a physician, it's a very nice model to work in, and so you need the knowledge, the change management, the software, the and a willingness to take a look at what would be a future world in which we had aligned patients, and really do some work here. I think the number one takeaway is, yeah, it may be complicated, but at this point, applying the technology is something that makes sense under both models. And I think that it's no longer necessary to kind of time it where you get where you think, boy, I've got at least 75% of my patients in an ACO are at risk in order for me to really do well clinically and financially. You can do it now, bottom line.
And it makes sense to get started on this stuff because I think you're quite right that, due to the environment and the way things are changing, this isn't going to go away. A lot of providers may not be very familiar with the value-based modifier program, things like that, but all of this is going to grow over time. And so it's incumbent to really get started on the process and start to understand it, I think.
Absolutely. And it does appear that most of the new, new revenue that's available to practices is built around these models. So if you think about just the coordination of care for patients, the transitions of care payments. So now, if a patient is leaving the hospital and you're providing care for that person in a transition in care, you can bill for it. That's a fee-for-service kind of a code, but it's fundamentally a population health effort. And so understanding who qualifies, understanding who you're taking care of, is really important to you financially. Then if you think about it from the patient's point of view, I mean, as an ER doctor, I can tell you that the better we get at pain management, the worse we get at discharge instructions. I send patients home from the emergency department with a migraine, and then I call the patient the next day to say, hey, how are you feeling? The medications I've got are effective enough. The patient barely remembers being in the emergency room at all. So, the patient experience where you're really wrapping that patient in an intimate, clinical milieu in which you are really, seen as paying attention to that patient, it's just so much better of an experience. The patients really appreciate it.
All right, well, we're to our question and answer session. We've already got some questions from our audience, but if you've held your questions, please do feel free to type those into your chat area, and we'll get to as many of them as time allows. So our first question is it safe to conclude that data analytics and streamlining care is the key to successful outcome measures, treatment, and prevention in care?
I think under the current contracts that the answer is yes. In 5 years ago, even when it was pretty much still all fee-for-service, the key to financial success was, trying to see as many patients as fast as possible, maintain 100% booking of your office, and frankly, particularly if your waiting room was mostly full all the time, you didn't have to worry about access to care or any of your care processes. You just wanted to be more efficient about getting patients through the door. I think at this point, as you start to be able to say, there is at least some group of patients that I need to be clinically successful around in order to be financially successful, first thing is you got to spot them, and particularly under an attribution model, those patients may not even be in your EMR, right? You'd like to think they are, at least once, but they may not even be in your EMR. You've got to understand the payer data set just to be able to say, who do I really got to go see? And so, without analytics, you are driving blind. And then once you have the analytics, shame on you if you're not redesigning your care processes to take advantage of the additional insight that you got from putting those in place. But I think that, analytics only goes so far. Every provider I've talked to about this, analytics alone gives you a situation where you're saying, okay, doc, here is your problem in discrete detail. Or here, care, office management, this is your problem in great detail. The next question, of course, is now what? How do I actually engage those patients differently? And if your answer is, well, leave that to the clinicians in the office, I think you're really, that's just one more thing to add to the physician workflow, and it's just going to kill them. And so, the thing to do is you need the engagement as an integrated part of this. And there's, a variety of people that can do that for you. But, don't neglect the inbound phone calls, the inbound reaching into the practices as a key opportunity to grab people's eyeballs that are already invested in calling your practice. They have their phone your phone number. They're willing to talk about care. That is a key aspect of it.
Well, I'm so happy that you bring a physician perspective to this as well, because we do certainly, we at Form and Approve, we work with providers all the time, and there's a lot of anxiety out there with all the transitions, even in just this year around everything from ICD-10 to Stage 2. There is a feeling of kind of being besieged a little bit by change, and so recognizing that physicians are under a lot of pressure right now is sort of the beginning of understanding how to address some of these problems.
Well, and I think it's really interesting. Again, go back to my grandmother, who, when she died, this was well before the age of HIPAA. We got this big chest, when she died, and it was her medical records, and they were all on index cards, and a couple of staples would staple a couple of index cards together. That was somebody who had a complex medical history. But if you were to, my grandmother reading her index cards really knew how to take care of people. It turns out that, the documentation requirements for more of a population health management, they make more sense, frankly. So, I'm encouraged by, the place we are heading to as a place where I would rather practice medicine, frankly.
Well, we have a couple of related questions that I'll ask together. One is, do EMRs have native tools for tackling some of these problems, or some better than others? And the related question is, has Rise Health integrated their solution into EHRs, and what does that entail?
Yeah, absolutely. So they have to. So I'd say that, when we were down at HIMSS, you could see a number of electronic medical records that were coming to bear with, population health tools. And, some things like health risk assessments and other kinds of tools that are more documentation, a lot of electronic medical records are starting to have. And I think that that's a good thing. There's no question that if you are subscribing to a good EMR, that those tools will be there, and those are a step in the right direction. The problem is, again, that with most of the EMRs is, again, the breadth and the depth. My impression is that most of the EMRs have deep information on the patients that you have seen, and they have, deep information on, your visits. And some of the EMRs actually, integrate across a broad area. So you might have a single electronic medical record in the hospital and in the provider offices. And that's wonderful. Again, great start, particularly for things like transitioning care. However, if you don't know that this patient is a snowbird in Chicago, everybody who has even a lick of sense is currently in Florida. Like that right now. And so, if you don't have the payer analytics, you don't have the payer data coming into your tool, you're missing all the medications that are being prescribed to that patient. You're missing all the history that's going on. You're missing all the visits, and that person could be at Mayo Jacksonville having their colonoscopy. You just don't know. And so, I'd say most EMRs don't have a window into the payer data sets. They don't have the breadth to really do great population health. And so I think you're going to find that those tools tend to fall down. Now, have we, and in the same way, only payer data isn't on a time resolution that's going to get you to be able to be clinically effective. So both approaches, really need more work. In terms of Rise Health, yes. So we, in order to do our work, we have to integrate into electronic medical records. And so getting data out of, NextGen and Centricity and, Allscripts and these kinds of things into our applications is, of course, critical to our being able to do our work. But also being able to push information back in and say to the doctor, hey, doc, your care coordinator in your office has had the conversation with this patient twice. They have called in 2 other times to talk to one of the MAs, and every time we're trying to get that patient to get a flu shot. Now here comes the patient into your visit. So, you know, they see the patient, they click on the little phone note flag and it says, hey doc, this patient just does not want to get a flu shot. Any chance you could talk them into it, right? That's the kind of clinical integration that I can get behind, because that's actually useful, helpful, succinct, and it's targeted. And I don't have to know as a physician that the reason that that's sitting in front of me is because that happens to be an ACO patient. You know, we did an eligibility check and the patient's still eligible for those services, and the care coordinator took care of that. I don't have to know all that. I know that, boy, I'm really going to put the tongs to this patient because they're 80 and they need a darn flu shot.
Well, maybe you could tell us a little bit about what Rise Health does, because you know, we've had some questions about what your capabilities are, and I think a lot of providers are looking for help around some of these issues. So if you could just briefly describe some of what Rise Health can offer.
Sure. Well, you know, no surprise given the tone of the conversation today. You know, what we're really focused on is changing the customer service experience for the patient and using every single time a patient reaches out to you for customer service, turning that into a clinical encounter. In order to do that work, we have to, because you need then at the point that the phone is ringing to know all of the information about what that patient needs and, you know, what that patient is how risky is that patient. We have a population health backbone which also provides great analytics. So, you know, we will bring in, you know, multiple payers, multiple EMRs, into a centralized database, and then provide you with analytics that show you, you know, who are your, you know, highest cost patients that are your patients that have been attributed to you as an ACO, or frankly, you know, who are patients that are, you know, are fee-for-service patients but have, you know, services that they should be getting that are things that are already paid for by the payer. And so then we have this patient engagement platform which wires into your voice over IP system and your communications, so that when a patient calls in, you know, if that patient has, you know, a recent discharge from the hospital with diagnosis of congestive heart failure, that you are under Medicare rules, you know, are responsible for that patient's readmission, then that patient, you know, never gets the front desk. That patient goes that goes directly to a RN care coordinator. And then what we do then is we transform the practices into a more team-based care approach. So we'll have payers that will, you know, be interested in our insights. And so we currently do this work for, you know, Blue Cross Blue Shield of Tennessee and North Carolina and others. But we also, you know, we think of ourselves as a provider company in the business of trying to, you know, align clinically with providers to do great care, improve their practice efficiency and financials, and also improve the patient experience. So that's what we do. It's our reason for living.
Well, we have time for maybe one or two more questions. This is something we've sort of touched on a little bit, but it seems like the answer must be yes. But I want to hear what you have to say. The question is: does population management, does it require an HIE to work? Interesting.
That's a great question. So, you know, healthcare information exchanges. I am an absolute, you know, passionate believer in interoperability of healthcare data. You know, I think that that patients have the expectations these days that you get coordinated care. You don't get extra points for coordinated care. You know, that's their expectation, and they also expect that, you know, your data, their data, is going to be respected in private, but is also going to be in a place where it's useful when they need it. And so I think that a healthcare information exchange is a fantastic idea, and I think that it's really important work. And so, you know, I am very much in favor of healthcare information exchanges. You don't need them necessarily to do your work. You need the data, and you can aggregate it into a tool, and you can go forth and do the work necessary to do population health. But boy, does it sure benefit. What I would say is, you know, to put it succinctly, population health is the reason an HIE exists. It is the best use case for a healthcare information exchange. And so I think that now that people are, you know, there's been mixed success with healthcare information exchanges, not because the products aren't good, because the products are good. You know, the Optum axolotl and the Medicity from Aetna. I mean, these are great products, but there hasn't been the use case, and now that the incentives are aligning, the use cases are there. And so I'm excited about healthcare information exchanges. You don't need it, but boy, it sure helps.
All right, well, I think we have time for maybe one more question, and this is about MU Stage 3. Everyone says that Meaningful Use 3 is going to be about population health. What is that likely to look like?
Well, I have my suspicions. I think that, you know, there has been a lot of focus on interoperability. So I think that Meaningful Use 3 will continue the focus on meaningful exchange of healthcare information and standards-based exchange of information. I think that being able to consume as well as generate a continuity care document so that you're in a position where you can say, so that you can manage those transitions in care, I think that that's going to be a significant part of it. And I sure hope so, because that really powers the model of doing great integrated team-based care. You know, I think that that's wonderful. And I think that, you know, some of the, you know, I think that evidence-based medicine at the point of care will be a part of that. Beyond that, I really don't know. I mean, I think that, you know, the population health is about, you know, getting analytics in front of you and understanding, you know, things at the point of care the right way and making sure that you have the ability to do a registry. So creating a registry might well be a part of it. But let's just say that that meaningful use has been, you know, I think it should always have focused more on interoperability. I think that as long as they focus more on interoperability and continue that pressure, I think that it'll be a win.
And didn't the director of ONC say that interoperability will be solved by 2017? I think I read that recently.
Oh, you know, talk about, you know, that is a wonderful statement.
I certainly hope it's true.
Yep. Before my career in medicine, I worked at a little company called Discover Card, and so and that financial company, you know, the nice thing about it is $1 is $1, cent is a cent, and yes, you might have to convert it into francs, but it's still just a percentage of $1 in most of the systems, right?
Relatively simple.
So the problem is easier, right? It really is. When you think about the fact that, you know, I could give you 4 milligrams of morphine and you'd feel better with your kidney stone, or you might need 8 milligrams of morphine. If I gave you 8 milligrams of fentanyl, you'd be immediately dead, you know, and because the dosage range on that is in micrograms. Just the very simplest problem in medicine is so much more complicated than financials. So, you know, as we go forward, it's going to take a lot of work, a lot of heavy work to get to true, really great interoperability. And I think that there's some companies out there that are starting some great work. I think of Charlie Harp at Clinical Architecture, you know, others that are really doing the hard work around interoperability. These are, you know, these. I hope that 2017 represents that date. My guess is it's a year or two beyond that. But just the continued pressure on it, I think, is great for everybody.
Yeah, and the continued focus. I mean, they're making progress, and I do think there's reason to hope that they're going to continue to really hack away at this problem. But it is certainly a formidable problem.
It is, but you know what I've been really impressed with is the payer data sets. You know, really give you an awful lot more clinical information than they used to, and some very interesting companies are out there taking things like, you know, X12 transactions and creating fantastic, you know, clinical visibility out of them, and so, you know, we benefit from that. We'll get data from anywhere. The easier it is for us to get data, then the better our systems work, and the sooner we can have that great conversation with the patient. So I think that's going to be a really important part of the future here.
Well, thank you so much for joining us today, Dr. Crockett. This is truly fascinating, and it's a real pleasure to be able to share your expertise on these questions.
So it was a pleasure. Thank you.
Well, to our audience, I'd say please do visit www.risehealth.com to learn more about how they can help you with these issues and to continue the conversation. They offer a world-class suite of products around patient management, analytics, and data integration. So go to the site and learn more about it. You can also email info@risehealth.com to learn more. Format Approved offers tools to help you meet meaningful use, PQRS, and HIPAA requirements. For a deeper understanding of meaningful use, visit formedtraining.com to take our Certified Meaningful Use Professional course. This course covers both Stage 1 and Stage 2 for both eligible professionals and eligible hospitals. If you need a risk analysis, visit www.formedservices.com to look into our services there. Please join us for the next Learning Lunch. You can visit formedapproved.com and click on the Learning Lunch button to learn more about those upcoming events. The Learning Lunch button will take you to the list where you can learn more about each one and register. Our next Learning Lunch will air March 11th and has the title Recruiting in Healthcare for HIT Talent. Certainly another problem that we hear a lot about these days. Thank you for joining us for today's session, and we hope you'll join us for the next one.